Good afternoon. I'm Dr. Jerry Bigby from the School of Nursing at Boise State University, and I welcome you to our Brown Bag Research Seminar today. And today we have a wonderful couple of nursing scholars who are going to be presenting on their research, measuring collaboration between skilled nursing facilities and hospice agencies, with our own Kim Martz and Dr. Gail Girding, who are going to be presenting this area of research. I do want to let you know that we are recording this session under our Echo 360 system, and our hope is that it will be posted on our school's website so that all of our colleagues will have access to it. So when you ask a question, we ask the presenters to restate the question to make sure that everyone can hear them. So thank you all for coming, and we'll be back here again next month. So stay tuned, and thank you. Kim.
Thank you, Jerry. Thank you all for coming this afternoon. We're going to talk, as Jerry said, on the perceptions of coordination of care between hospice and skilled nursing facility staff. My colleague here, Dr. Gail Girding, will be helping me out with this presentation. The study was actually funded by the College of Health Sciences in the Office of External Funding. But we've also worked in collaboration with the Idaho End of Life Coalition. I am a member of the coalition, and I sit on the Hospice Policy Committee. And there was some discussion, a little background on how we can actually start to implement palliative care guidelines into nursing homes. And so we started to kind of maybe just start to work backwards. Well, what's really going on? And how are they working collaboratively together in hospice? So what's going right, and how can we springboard from there? Okay, so that was kind of a little bit of the background on the study. Some information about seniors. The number of seniors, as some of you know, is expected to double in the next 30 years. And some of them, of course, are living longer and dying of chronic illnesses, and some of them in the long-term care setting. And this is going to be, extremely important as in, January of 2011, there's a big thing happening. Does anybody know what that is? January of 11? What is that? The first baby boomer will turn 65. And so that is actually going to be this springboard for this whole silver tsunami, as they call it, that is coming. Yeah, I like that term too. It was kind of a fun term, but we are living longer, and especially the baby boomers, and eventually these chronic illnesses are catching up, and some of them are dying in the long-term care setting. But the numbers of older Americans who die in this setting is increasing each year. And it's estimated that currently 1.6 million live in a nursing home, and 20% of those folks die there. The proportion of people living in nursing homes significantly rises with age. So it's not the 65-year-olds necessarily, although they do say that some of them will spend some time in a nursing home, but maybe discharged from there. But the fastest growing segment of the population is that 85 plus. And those are the people who are sometimes needing this type of care and dying in nursing homes. A little background on this population. It's projected to increase 36% from 2000 to 2010. So it was estimated 42 million people to 55.7 million people. So that's a big, big jump. In 2020, that number is expected to be 6.6 million, a 15% increase. Okay. And this was just another interesting statistic. From 1999 to 2008, the number of persons age 100 or more increased 147%. Yeah. So from 37,000 to 92,000. So we expect that number to keep increasing also. That doesn't mean they'll all be in the nursing home, but there are some projections of, how well they're going to be and how much need there'll be. In 2020, they say 40% of all deaths of older adults will occur in a skilled nursing facility. Many studies report that the quality of care of dying residents is poor. Okay. They report unrelieved pain, poor symptom management, family dissatisfaction with the coordination of care, a lot of hospital admissions. So there's a lot of problems going on with the care. So when we were starting to look into the literature about the study, we found that there was a funded project from Robert Wood Johnson on how these hospices collaborate with skilled nursing facilities. And they looked to try to find solutions. They were looking at successful partnerships resulted, of course, from well-planned efforts. So part of when we're doing the literature search, we looked at this document and actually took some of this information as part of the questions to find out, were they doing any of these collaborative things that work well together? There isn't a lot of literature out there on specifics for hospice and skilled nursing. The one study we found, 40% of hospice staff reported negative experiences in nursing home adherence to the plan of care. They also reported that they had negative experiences regarding medication ordering policies. They had negative experiences from every supervisors, managers, nurses regarding pain management, coordination, care planning, and the differences in the perception of philosophy of care between hospice and skilled nursing. And that's a big issue. The regulations, for nursing homes are all about rehabilitation. And of course, for hospice, it's just not curative care, but comfort care. So they really differ in their philosophies, and basically because of the regulations. So the purpose of the study was to describe the actions and behaviors of hospice and skilled nursing facility staff that intersect to support end-of-life care of a resident in a skilled nursing facility. It was an exploratory descriptive study of perceptions of the actions of hospice and skilled nursing staff. We did have IRB approval, and the survey tool was kind of quite unique. It was developed from several existing survey tools, including, like I said earlier, that collaborative document. We took some information from that collaborative document. We also took some information from the City of Hope Quality of Care at the End of Life survey. Parker Oliver's study that I showed you a little earlier, we got permission from her to use her survey of hospice providers, along with self-assessment of clinical competency and concerns in palliative care. So we incorporated a number of different things in the tool, and was really pleased to see that when Gail ran the stats on this survey, that it came up to be a very reliable tool. So if you'd like to know statistics on that, Gail will be happy to tell you those. Okay. The survey was broken down to the following categories. So we looked at collaboration, we looked at skilled nursing and hospice experiences, and then we looked at the benefits and the barriers to care. So we asked in the skilled nursing and the hospice experience, we asked skilled nursing to look at themselves, and hospice, and then kind of vice versa. Hospice to look at themselves and hospice to look at skilled nursing. So if that gets a little confusing when I'm talking about that, kind of bring me back around, because I'm so in the data that I may not explain that really clearly. The initial data was collected at the Dying Well conference in 2009, last summer. And then additional surveys were mailed so that we would have a better representation of facilities across Idaho because of the differences in the rural and the urban settings. 200 surveys were returned, and 30 of 44 Idaho counties and all 7 health districts were represented. 95 hospice providers answered the survey, and 91 skilled nursing facility survey providers answered. 175 of surveys of the 200 returned demonstrated working with a hospice patient in a skilled nursing facility. So that was one of our qualifiers. You had to have worked with a hospice patient in a skilled nursing facility. So this was kind of looked like what the demographics look like, and the orange is the representative of the hospice, and the yellow is representative of skilled nursing. And we did, it is a multidisciplinary facility, and both agencies are very multidisciplinary. So As you can see, the orange were the RNs. Most of them from hospice answered the questions. And in the skilled nursing, both RN and LPN was equal. So I was really glad that we got both of those perspectives in there. Lot more CNAs with the hospice agencies, which was kind of surprising. We thought maybe we'd have a lot more CNAs also in the skilled nursing facility. Social work, key in both agencies, answered almost the same. More administrators and directors of nursing from skilled nursing answered. And of course we had an other category, but we don't know what other meant. Okay. Cook? Yeah, it could be.
Maybe it might have been dietitians or OT, PT, or different kind of people that work.
Yeah, right. And if you couldn't hear that on the camera, we project that maybe they're occupational therapists, physical therapists, dietitians, could be pastoral care, could be other disciplines that answered. Okay. So in the years of experience, the range of years in skilled nursing was from 2 months to 48 years, with the largest percentage, 80%, being between 1 and 20 years experience. So that's a lot of experience, 20 years. Range of years in hospice was from less than a year to 29 years, with the largest percentage, 85%, between 1 and 10 years of experience. Okay. So when we look at like we said, this was broken down into those 3 different categories. And collaboration, the first one, where we found that they intersect was that both skilled nursing and hospice agreed that they had the knowledge and the skills to care for dying residents, that there is an effective continuity of care, that pain is effectively assessed and managed, which is answered quite differently when you see later, and family meetings are conducted in a timely manner. Okay. So this is where they agreed on collaboration issues. The significant differences occurred when we looked at 26% of hospice providers indicated that regular assessments of the partnerships of those agencies always occurred, while only 9% of skilled nursing indicated this assessment occurs. This is again back to that document that says, that mechanisms are in place, that regular assessments of how this partnership is working is happening in these agencies. And hospice was seeing it differently than skilled nursing was, that they think these assessments occur, and skilled nursing does not necessarily see that this is occurring. 60% of hospice providers stated that there's always assessment is used to identify people at risk for grief and bereavement, while only 22% of skilled nursing providers reported this occurs. Again, this is a difference, though, in their areas where grief and bereavement is not necessarily a part of skilled nursing, where it's tremendously a part of hospice. So very much a difference in their philosophies. 42% of hospice providers indicated they were always sensitive to diverse religious or spiritual needs, while skilled nursing reported only 17% were always sensitive to diverse religious or spiritual needs. Again, possibly education differences there. Pastoral care and chaplaincy is always available and effective. The hospice said 61% of the time that this is always occurring, while only 27% of skilled nursing rated that always occurs. Again, very much part of what hospice does, very much not what skilled nursing facility does. When asked to rate if hospice supported skilled nursing in facilitating the residents' advanced directives, 54% of providers rated this always occurs, while only 21% of skilled nursing providers rated this as always occurring. So they're not seeing that the hospice is helping them with the advanced directive, facilitating advanced directives. The largest gap we found was that 44% of hospice perceived that hospice always attends the death of a resident, while only 5% of SNF reported that this always occurs. So that was just a big gap. And We can speculate as to why, but we weren't really sure. We can talk a little bit about that in the discussion. As far as the collaboration benefits go, the benefit of hospice to a skilled nursing facility resident, hospice saw that 51% of the time as positive and most positive. Skilled nursing said only 22% of the time they felt that was a positive experience, positive for the resident. It could be that they feel they're already doing this work and that, they didn't see hospice as particularly beneficial. Ability to identify hospice patients. Hospice said they're 33% of the time, that's more positive, they're able to identify hospice patients, while skilled nursing, 26% of the time they did feel they were able to identify a hospice patient. The effectiveness, again in collaboration benefits, the effectiveness of hospice education programs in the skilled nursing facility, this was really interesting. Hospice providers felt that 25% of the time it was a positive or most positive effectiveness, where skilled nursing said only 11% of the time. So they're not feeling that they're getting their educational needs met, it looks like, from hospice. And communication with hospice and skilled nursing facility staff, 33% of the time hospice saw this as positive, where skilled nursing saw this only 16% of the time as being positive. And communication comes up over and over again, as you'll see throughout the study, as being problematic. Hospice and skilled nursing perceptions of hospice care in a skilled nursing facility. And this is where we asked, again, this kind of gets a little confusing. We asked hospice to answer about themselves and about skilled nursing. We asked skilled nursing to do the same, to ask about themselves. So when we looked at comparing, both agencies indicated that skilled nursing staff does a good job of contacting hospice agencies with changes in conditions of the residents and problems. Okay? They both also agreed there were real different difficulties understanding regulations. And this wasn't just one-sided. Hospice had as much problem understanding skilled nursing regulations as skilled nursing didn't understand hospice regulations. So we can see that they're causing, the regulations are confusing. And this was well noted in the qualitative responses. There was an opportunity for them to just write in some comments. And oftentimes this was a huge problem, that the regulations were causing difficulties. So 33% of the time to 38% of skilled nursing providers rated their ability to assess pain, use as-needed pain medication, and have a good knowledge of pain management as good to best. So they thought they were kind of doing okay on pain and pain management, while 17 to 22% of hospice providers thought that skilled nursing had a good ability to assess pain, use pain medications as needed, and have a good knowledge of pain medications. So skilled nursing saw themselves doing a better job with that than hospice did. Okay. Again, 19% of hospice providers rated skilled nursing facility coordination efforts as good to best, while 25% of skilled nursing rated their coordination as best. So again, a difference in the way they see themselves. Skilled nursing saw it being a little bit better than hospice saw them. 32% of skilled nursing providers rated their ability to identify hospice patients as good to best, while 18% of hospice providers rated their ability to identify hospice patients as good to best. So they see each other completely differently. The largest difference was demonstrated when asked to rate the benefit of hospice to a skilled nursing facility resident. And this question comes out quite a number of times in the study, as you see. So they asked it in a little bit of a different way. Only 15% of skilled nursing providers rated this as good to best, while 47% of hospice providers rated this as good to best. So again, skilled nursing is not seeing hospice as a benefit, and they may feel that they're already doing all of this work. When we looked at what were the 3 biggest problems with working with hospice patients in a skilled nursing facility, hospice felt the proper use of as-needed medication, the communication and miscommunication, and the skilled nursing facility staff turnover was a big problem for them. Interestingly, the lack of knowledge about hospice was fourth for hospice. They thought, that was problematic, but not the top three problems. Okay. And we'll talk about that in a little bit. What are the three biggest problems with working with hospice patients in a skilled nursing facility from the skilled nursing perspective was communication and miscommunication. So they both felt it was really problematic, skilled nursing seeing it first. And the lack of knowledge about hospice, they're telling hospice, they don't really necessarily understand the regulations. And the staff, their own shifting from rehab to palliative care. When their regulations are telling them it needs to continually to be rehabbed and pushed up, and you're going to get dinged for things that are in direct conflict with end-of-life care. So they're seeing that as problematic. What are the benefits of hospice to skilled nursing? Hospice sees that pain management is the biggest benefit for the residents, that patient and family support and education was second, and that medications, durable medical equipment, and volunteers were really strong benefits for the resident. And skilled nursing looked at that patient and family support. They really thought that was good, that the patients and families had a little more support than they were able to give. The psychosocial support was noted also as high. And then they list pain management as key too in assessments, but it was third as far as their benefits. Okay. So implications for practice. We looked at some issues on this and continuing to improve educational programs for both skilled nursing and hospice providers. This was really important in terms of the regulations. They can really benefit from, kind of trying to understand that. And the palliative care. One thing we looked at, and we haven't looked at it statistically in the data yet, was we asked if they were part of a dedicated team. So hospice have dedicated teams, and skilled nursing have dedicated teams where they say you'll always work with this hospice, and or this skilled nursing facility, and then they build relationships. And then there's, a little bit better working together in terms of that. So the dedicated teams, then they could actually also then continue to improve the education, and about palliative care and about regulation. So we really need to kind of look further into the data for that dedicated teams items. The development of communication patterns, and so we want to look at what's going wrong in the communication, how are they miscommunicating. And there could be the development of integrated assessment forms. Because of the differences in care and who's in charge of what, they have a lot of difficulty. Are you giving the bath, or are we giving the bath? And sometimes that comes down to a payer idea, but if they had an integrated assessment form, it could really help the coordination of care. And that also goes into that coordinated protocol, finding some way to coordinate the care through a protocol. And then, I talked about this already, but it kind of fits into the education, examining the benefits of designated teams, and specifically policy implications when you look at the regulations. There's a lot coming out currently in the literature about new Medicare benefits for end of life in the long-term care setting. So hopefully, and surprisingly enough, though, they don't have a lot of information in terms of research on quality. They don't have hospice utilization, costs. They don't have a lot of that data collected yet, and especially in the quality area. As many of you may know, the quality measures for skilled nursing are, like I said earlier, all towards rehabilitation. And then if you look at the National Hospice and Palliative Care Organization standards of quality, They don't even fit. So measuring quality is really kind of hard in that setting. Any questions? Feels like some of my slides aren't there. I don't know why. Oh, Leonie, and then Pam.
I wondered on your instrument, I was thinking of the results that you reported on 16% of hospice believes this 5%. Was it a 4-point Likert scale?
Sure. I have a copy of the survey if anybody would like to see it. Yeah.
The one was always. What was that second category?
So
Those numbers have been.
well, in the collaboration piece, that was a Likert scale, and it went always to unknown. So always, usually, occasionally, never, unknown. And then when we're looking at actually the clinical aspects of it, they were best to worst. Okay. And then kind of changed around a little bit, positive to most positive. So there was quite a number of ways we evaluated it. But I will let Gail speak to more of the statistical analysis of that.
And I didn't know what was going to be Echo 360'd, so here I am. To kind of answer your question, like with the first part where we looked at the benefits and collaboration, I actually ran chi-squares on that because there was, in terms of the Likert scale, it was always, usually, occasionally, never, unknown. So I ran chi-squares on that just because I felt that that would give us a better idea of where are they different. When we did the experience, because it went from worst to best, and Likerts are supposed to be summed, and then you can do t-tests. I did t-tests on those, again, looking at, excuse me, where the differences were. But we decided to report more in the percentages because that makes more sense when you look at what you're trying to demonstrate is, are they collaborating or not? How are they perceiving this experience? And I think one of the things that we really want to emphasize here is we really were measuring their perceptions of what they thought was going on, which I think was fascinating with the going to the death. Hospice thought they were there, but skilled nursing facilities did not perceive that they were. So you've got a very interesting juxtaposition here of what they're perceiving and perhaps what really is occurring, because there's no way to actually measure that unless you stay there and count it.
Right. So if you add usually to the totals,
if you add usually,
always and usually together.
What we found that was fascinating to me, most of the time I did, because it's one of those real interesting pieces of statistics. You divide them up in these little bitty increments, and then when you report it, you collapse them. It was like, okay, that made sense to me. I often did put the always and usually together because it seemed to me that was where they were. And some of the ones that we're not reporting they were in the middle. I mean, again, they really were not. They didn't really see it as good, bad, or indifferent. And that in of itself, I thought was fascinating. I think I pointed that out to her a couple times. Look, they don't know. But to kind of talk about the dedicated teams a little bit, I actually did run some of that data, and the reason we didn't report it is because it's, I think, promising in demonstrating some very different answers. Because what we saw, the trend was when they're dedicated teams, their perceptions were different. They saw things as happening better and more coordinated and more collaboration. So that's one reason we held off on that. We want to actually just really delve into that particular piece. And because we really only looked at 175 responses, it's not a huge N. So when you collapse it to the dedicated teams, because there really weren't that many that I forget. I'm not sure it was even 50% that actually had dedicated teams. So it was a smaller end. So we really have to be careful with the results of that. Yes, ma'am. She's thinking. No, go ahead.
I wondered if, when you guys looked at your data and ran it, did you do anything with finding out whether people considered themselves urban or rural?
Okay, what the question has to do with whether we looked at urban or rural. Actually, we have the ability to kind of look at that because that was one of the reasons we mailed surveys out, because from the conference, most everybody was from this area. So we mailed them to the more rural areas of Idaho. I did look at that a little bit, but I really couldn't see that anything was showing up specifically because of the small n. And that was very disappointing, because that was really the point of the mailings, was to try to get a good representation of urban versus rural. And we did not really succeed in that, which kind of was sad. Yes, ma'am?
In the statistic there, it said there were 44% of the skilled nursing facility people felt that the hospice nurses had not attended deaths. And I was just wondering if the hospice people felt they had been attending. Maybe that was 44% their perception. Were the hospice people specifically referring to skilled nursing facilities, or was it outside?
Well, in terms, the question that was asked was, with the 44% of hospice responding positively to attending the death, was that specifically to a skilled nursing facility? The question in the survey does state, it's actually your overall experience focused on skilled nursing facilities, rate these. And so our hope is that they rated it based on skilled nursing facilities. But your question, it begs another question, is that really how they answered it? And we don't know. But because the focus was on caring for a patient in a skilled nursing facility, we're hoping that's how they answered it. Yes, ma'am?
Did you guys do any validity testing on the survey?
Yes, I did, because I knew people like you would ask. What she asked had to do with validity of the instrument. And because we took so many pieces from different instruments, that was another reason I ran the Chromebacks. Because, I mean, we really just kind of squished together many questions from multiple pieces. The overall Chromeback alpha from this was 0.858. Yeah, I was like, whoa. But it gets better. The Chromeback alpha that looked at the collaboration piece was 0.819. The Chromeback alpha for collaboration, the subcategory well, why do I have two collaborations? Hang on, let me see. The subcategory of care of hospice clients, in other words, how did they experience this in the skilled nursing facility, was 0.929. And I ran that a couple times thinking I had done it wrong. So I was very surprised at that. Again, knowing we had taken many questions from multiple instruments and put them together. So I feel pretty confident that this was a reliable instrument for this group, for this sample. Now, whether it would turn out that way for another sample, I don't know. But you know, they seem to respond to these questions. The reason we went down to 175 was because I looked across, and anyone who had not cared for a patient in a skilled nursing facility, I felt like they probably could not answer the questions focused on that population. So that's why we went down to the 175.
Was that your end then?
Yes. The 175 was the end we looked at. Now, the 200 was our demographics, and then I looked at the demographics with the 175, and the proportions were pretty much the same.
And then what was, how many in each group?
You want to see the slide?
Well,
It was 95 and 1 and 91 and, yes. And again, another one of those interesting little things that occurred. I was really surprised, well, not totally, but the number of RNs in hospice versus the number of RNs from skilled nursing facility that answered the survey. The other second largest group was social workers. So again, people who probably have a very strong invested interest in making sure that end-of-life care is looked at. And I think one of the things that I really would call, I said, come look at this, look at this. The regulations really were a juxtaposition of how these people could work together. And the literature states over and over again that the skilled nursing facility staff see the hospice staff as redundant to their care, and which really gives you insight into why they did not see it as beneficial. Yes, ma'am.
You know, I'm looking at the collaboration between these two, and in my days of long-term care way back, I mean, palliative care was part of, it wasn't just rehab. And, you know, I was in a rehab facility up in Moscow, so there were both of those aspects, but I wasn't aware that hospice is going into skilled nursing facilities and there's a partnership there, because that chasm of regulations, seems to be a barrier for those two, partnerships to get together.
Yeah.
And palliative care is also not reimbursable. So that's part of the problem too. Could be really incorporated really well into long-term care, especially in light of, there's 70% of long-term care residents are, have Alzheimer's or, dementias. And that prognosis is so difficult. So palliative care could be a wonderful, addition to their care. But again, regulatory issues do not have any structure for repayment. Mm-hmm. Mm-hmm.
Yeah, one of our next papers is looking at the regulation and policy issues. The philosophy care of this is different as well. I mean, in a skilled nursing facility, nursing home, you've got philosophy of care, which is, years ago was they were here to kind of live. Now it's really about rehabilitation, getting them feeling better, and discharging them. Whereas with hospice, it's really about helping them in their life with dignity. And so you have, again, a very difference in how they're approaching the resident.
Plus, just tagging on what you said, the things like conscience laws that are being considered all over the country don't make it any easier in terms of getting the philosophies more well understood. In fact, I think it kind of polarizes the issue and starts nurses kind of pulling away into one side or another.
Mm-hmm.
And so I think that's related to policy. I know I see the students talking about it in the classroom.
Mm-hmm.
Mm-hmm.
Yes, ma'am.
Maybe I missed this part, sorry. Can you speak a little bit to, as far as confusion with definitions? I mean, we're talking hospice versus palliative care.
Yeah.
Her job.
No, you're right, Molly. I didn't define any terms for this particular presentation, but if you want to talk specifically about hospice, to be able to be have hospice delivered, which is palliative care delivered, you have to have that 6-month prognosis. And then the Medicare hospice benefit will allow these residents to have an additional 90 days. They can re-up again for after the initial hospice period is over. They're allowed to live, but as long as they continue to have the 6-month prognosis, and as long as the physician does, and 2 physicians say that they are going to die, which becomes really problematic with, Alzheimer's and dementia, the prognostication.
They're more of a focus with care with like congestive heart failure patients and people that aren't necessarily fitting the bill for hospice.
Well,
But they're not going to get all that.
Right. The comment is about palliative care and the specific conditions that are chronic conditions that would warrant themselves better to palliative care rather than hospice care. And that's actually, was part of the impetus of this study, is that, palliative care could be really beneficial in a skilled nursing facility, especially with the chronic conditions that these older adults are having. But again, there's no reimbursement structure, and there's little training that goes on in the nursing homes for palliative care. There are white papers out there that say this is the best practices, clinical palliative care best practices, and they have a document that this big, and it's put to a nursing home administrator there. Do that in the nursing home, and there's no structure for reimbursement, and then they have to really educate their staff on palliative care. The hope is that, that we have more advanced practice nurses or those folks coming in and actually doing some palliative care consults and maybe helping the staff be able to deliver that kind of care. I think the demand with this silver tsunami is that we, baby boomers, will probably be demanding that type of care. And the very recent study that I just read in Health Affairs was on proposition for a new Medicare benefit, really calling for palliative care, calling it, instead of curative and instead of rehabilitative, restorative. So they're really kind of trying to change the wordings too to make it more acceptable, I guess. I don't know. Did that answer your question, Molly? Okay. 'Cause I didn't define. You're right. There's a real mix-up between hospice and palliative care. Hospice is really more about the reimbursement and the 6-month prognosis. But palliative care can be that type of care delivered long before the 6-month prognosis. Jerry.
I just wanted to say this is fabulous work. Congratulations on cutting edge stuff, and we all know how relevant this is. So great work. And I guess my question to you is, tell us about your next steps. Where are you going from here?
I'll let you talk to that.
Well, actually, she's in a DNP and a PhD program, really working on looking at regulation policy and end-of-life care, which I applaud. I mean, that's a big area of emphasis. I play two ends of the spectrum in terms of age. So she had this bad habit. I kept trying to tell her I really wasn't going to help her much. I'd give her, be a cheerleader, push her along. And I ended up getting very involved in the study just because of, I like statistics, which is sad, but also because this is really where my research initiated, was in older adult care. And so I am very interested in how this goes. And I think for us, both of us have looked at, like I said, we want to look at the data that we have on dedicated teams, and then perhaps actually going forward with another study looking at dedicated teams. And my interest is in policy. How can we use this to better the policy and regulations for older adults? I was just sharing, Leonie and I were just talking a little bit about how preventive care is a great buzzword. Everybody wants us to be preventive and do all this stuff. But if you look over time, there's some fascinating studies that will tell you that we live longer because of preventive care, but then what do our last few years look like? And so those kind of issues, I think, would be fascinating for us to pursue. I don't know if she wants to hang around with me a whole lot longer, but the policy issue is critical. If we don't look at the policy, of course, as a population person, if we don't look at the policy and change the direction that we care for our aging America, our aging adults, we're not going to get anywhere. And I think what's interesting to me is if you look at how the regulations have gone in nursing homes, where they've pushed to this rehabilitation piece, I think that was an attempt to try to help people feel better and get better in their aging, when in fact what it did is it limited the reimbursement. And so again, in a step trying to be helpful with our aging adults, we have interfered with that based on money. And so I think that's why policy must be looked at and how it works with older adults. There you go. Your turn.
I was just going to add to that, Gail. It's just that in part of changing policy, because when you look at significance and impact, that's I don't want to just generate knowledge. You really want to have some significance and impact, and in order to change the policy, looking at the fact that these quality data isn't collected, so this quality piece is really interesting to me. And the hospice utilization and costs, although I never would have been dreamed I would really be interested in money in any way, but it has to be looked at. It has to be presented so that the policy changes can take place if they have the data to support cost and quality specifically. So, does that answer your question? Anybody else?
Well, thank you all for coming.
Yeah, thank you.